The title of this study is called Timing of Lymphedema Following Treatment for Breast Cancer. When are patients most at risk? It was published in the International Journal of Radiation Oncology, Biology, and Physics in January of 2019 by Dr. Susan McDuff and Associates. The purpose of this study was to determine when the risk of lymphedema is highest following treatment for breast cancer and which factors influence the time course of lymphedema development. This study included 2,171 women with 2,266 at-risk limbs. Lymphedema was defined as a 10% relative arm volume increase that occurred greater than 3 months postoperatively to eliminate the risk of postoperative swelling with lymphedema. Measurements were assessed with pyrometry. The overall estimated 5-year incidence of lymphedema was 13.7%, and the greatest risk factors associated with lymphedema were high preoperative body mass index, or BMI, axillary lymph node dissection, and regional lymph node radiation. Women who received both axillary lymph node dissection and regional lymph node radiation experienced the highest 5-year rates of lymphedema at 31.2%. This was followed by patients who received axillary lymph node dissection without radiation at 24.6%, and lastly, patients who had sentinel lymph node biopsy with regional lymph node radiation had an incidence of lymphedema of 12.2%. Overall, the risk of lymphedema peaked between 12 and 30 months postoperatively in all cases. It should be noted that 64% of women underwent radiation in the course of the study. Further details of the percentages of women who underwent lumpectomy versus mastectomy, sentinel lymph node versus axillary lymph node dissection are discussed in the details of the study. For the entire course of the study, the risk of developing lymphedema is greatest within the first 3 years following surgery. Axillary lymph node dissection is associated with early lymphedema that occurs within the first 12 months. In contrast, regional lymph node radiation emerges as a significant risk factor for lymphedema after the 12-month mark, and this is considered late onset lymphedema. The risk of lymphedema for patients who received axillary lymph node dissection alone peaks at 6 to 12 months postoperatively, and the lymphedema risk for patients who receive both axillary lymph node dissection and radiation peaks between 18 and 24 months. Finally, the lymphedema risk for patients who receive sentinel lymph node biopsy and radiation peaks later on between 36 and 48 months, and the risk overall of lymphedema is less than the previous two groups. Further discussion of this study includes the difference between lymphatic system trauma following surgery, which is usually more immediate, and lymphatic system trauma that occurs as a result of radiation-induced fibrosis, which usually takes several years to manifest. Limitations of the study that should be considered are: 1, the study was not randomized. And number 2, this study did not address the impact of any interventions that may have been prescribed following lymphedema diagnosis, such as complete decongestive therapy and use of compression garments or compression bandaging. As with all studies that I'm reporting on, it's very important that a patient know his or her own risk and discuss any possible outcomes with their own medical team. My name is Lisa Berman Sylvestri. I'm a physical therapist and a certified lymphedema therapist, and my goal is to make us all lymph smart.